it gives us a wonderful fluorescence and a wonderful technically clear picture so that we can optimally use the technology. We use the Glyline 5 ALA as it is produced and marketed by the Medac Corporation. And just some interesting factors, Glyline should definitely be used by a neurosurgeon conversant with the surgery of malignant gliomas, as well as the in-depth knowledge and function of brain anatomy, who have then completed a supervised and optimal training course in fluorescent-guided surgery. The indications of use for the molecule, so Glyline is indicated for adult patients, for the visualization of malignant tumor tissue during the surgery of either a grade 3 or a grade 4 malignant glioma. The safety in children aged 8 up until the age of 18 has not been established, and we would not advocate the use thereof. There are no specific precautions in the elderly, except that they need to have a reasonably normal organ and liver function, then to optimize the use thereof. Glioblastoma multiforme is the most frequent primary brain tumor, accounting for approximately 12 to 15% of all intracranial neoplasms and up to 60% of all astrocytic tumors. In most European and North American countries, the incidence is approximately 2 to 3 new cases per 100,000 people per year. And with a median age of 64, the incidence then peaks at anything between 75 and 84. And as the local and international population are aging significantly and rapidly, we are seeing more and more malignant gliomas. The incidence of these gliomas are 1.6 times higher in male than in female patients, and up to 2 times higher in the Caucasian population group as compared to the African and Afro-Americans, and definitely lower in the Asian population groups. Specifically in contraindications for the use of the Glyline molecule in your patient would definitely be the hypersensitivity to 5-ALA, as well as patients with sensitivity to porphyrins. Any patient with acute or chronic types of porphyria would be an absolute contraindication. One has to take into account that these molecules get metabolized through liver and renal, and thus any liver and renal dysfunction would alter the amount of clearance and thus needs to be used with strict caution. In pregnancy, multiple animal studies have shown embryotic activity with 5-ALA plus the exposure to light, and thus it would not be advised. It is unknown if 5-ALA is in fact excreted in breast milk and interrupt breastfeeding for at least 24 hours after the treatment of 5-ALA in patients that are actively breastfeeding and would require the use of 5-ALA during her surgery. There are currently no data influenced by 5-ALA on fertility. Now, how is this molecule used? As I said, this is a molecule in powder form, and it's recommended that the dose used is approximately 20 milligrams per kilogram of body weight, and that would be ideal body weight. And it is ingested between 2 and 4 hours prior to the surgery. As you can see in this slide, we mentioned 6 to 8 hours. And I said 6 to 8 hours due to the fact that we wanted at least 6 hours prior to us getting to the location of the tumor, then to optimize the amount of 5-ALA accumulated within the tumor tissue itself to be used for fluorescence. We find that our peak levels of Glyline is anything from between 6 to 8 hours after ingestion, but these levels are maintained up to 16 hours thereafter, and thus with delayed or longer type surgeries, this should not be a problem. Glyline powder is ideally dissolved in 50 ml of normal tap water before ingestion, and the specific contraindication is because of its bitter taste that the patients do not mix it with any other than normal tap water to alter the absorption of the molecule. After ingestion, strong exposure of the eyes and the skin to strong natural light should be avoided for at least 24 hours. And specifically post-operatively, patients should not be put against a window or close to a window where they have the possibility of having exposure to natural light. Within the theatre complex, dim the lights and make sure that they are not under strong UV fluorescent light during the procedure as well. A couple of precautions. Glyline should definitely not be used by a neurosurgeon that has not been trained to use it, or as somebody that does not have an intricate knowledge of the functional anatomy of the brain. And the reason, therefore, is because Glyline shows tumor abnormal tissue and does not give you any information about the tissue's neurological function, and thus sometimes you have to stop and not remove the entire tissue that is tumorous due to neurological function that might be compromised. Some common side effects of the molecule. These side effects are reasonably rare, but they do include anemia and thrombocytopenia in 1 in 10 patients. Thromboembolisms is a rare occurrence, and specifically in our day and age, where we talk about vaccines and thromboembolisms, it is a reasonable common side effect. Nausea and vomiting, increased liver enzymes due to the fact that this does get metabolized by the liver. Neurological, that is either hemiparesis, aphasia, and convulsions. Common side effects, as you can see, in approximately 1 per 100 patients. Uncommon side effects include hypotension, photosensitivity reactions, and photodermatosis, specifically in patients that are sensitive or undiagnosed porphyritic patients, and then patients develop diarrhea on the odd occasion. I must say, out of our experience, we haven't had any of these specific side effects except for photosensitivity, and that has easily been remedied. So how does it work? Well, the 5-ALA is an essential amino acid. This gets uptake within the tumor tissue and then broken down to protoporphyrin 9, which then accumulates within grade 4 and grade 3 astrocytomas. And this is due to the higher uptake of the 5-ALA molecule within the tumor tissue, or, as literature shows, an altered pattern of expression activity of the enzymes involved in the hemoglobin biosynthesis of tumor cells. Higher 5-ALA uptake in brain tumors due to the disruption of the blood-brain barrier, and also due to the increased neovascularization of tumor tissues, and then subsequently an overexpression of the membrane transport within the glioma tissue cells. After the protoporphyrin gets absorbed within the tumorous tissue cells, and you expose it to the FL400 light, or the blue light of the microscope, at approximately a wavelength of 400 to 410 nanometers. This then excites the protoporphyrin 9 within the tumor tissue cells, and this strongly fluoresces. The peak light frequency at which it fluoresces is approximately 635 nanometers, and this can then be visualized under the appropriate modifications to a standard operating microscope. In our case, the OH5 by Leica with the FL400 microscope molecule. The fluorescence emission can be classified as an intense or a very deep red fluorescence, corresponding to the solid part of the tumor. As you saw in the small little video, there was a solid core of tumor fluorescence, and then a vague pink fluorescence, usually on the periphery, that corresponds to infiltrative tumor tissue cells within the penumbra, whereas normal brain tissue lacks the enhancement of the protoporphyrin 9 levels, and this they would fluoresce to a violet blue hue, and the normal brain tissue would appear normal, and brain tissue would be blue in that case. So, as we said, glioma cells take up more of this active substance, and this is then converted to protoporphyrin 9. And when these cells are then illuminated under low light and with a specific wavelength, the protoporphyrin 9 within the tumor cells starts glowing, and the normal tissue then appears normal and blue. This allows for the surgeon to see the tumor more clearly during his surgery and to remove tumor tissue more accurately. This small video clip that I'm going to show to you now shows how we use the 5-ALA during a assisted surgery. As you can see from the small video clip, the left side of the tumor cavity is brightly pink and fluorescent, And every time that you see blood filling the cavity, people tend to be afraid that the protoporphyrin 9 or the gliline is adherent within the red blood cells, which it is not. So blood does not affect your fluorescence. This then subsequently allows us to take biopsies of the bright fluorescent areas within the tumor tissue itself, and then to get an optimized representation of the tumor so that we have a good representation for a histopathologist to do the histoanalysis to confirm our diagnosis. As you can see, every time that the tumor cavity fills up with blood, once that's sucked away, you can clearly see the fluorescence because it is not bound to red blood cells, but in actual fact bound to the tumor tissue itself. So what are the limitations of use of the gliline molecule? Well, you need to alter between the blue light or the filtered light and then the normal white light for optimal surgical visualization. Theater lights need to be dimmed to some extent to allow proper visualization. And as you can imagine, if you constantly move between blue light and the white light, when you have got the blue light filter on, you cannot visualize the normal parts of the brain adequately or as clearly as you would under a normal white light. And in subdued theater environment and dimmed lighting, there could be some difficulty in having a peripheral view of the brain and not only just focus on the area of fluorescence. Specifically, when one has bleeding out of your visual field, one tends to focus on the area where you get fluorescence, and that might compromise patient care. ALA induced fluorescence of brain tissue does not provide information about the tissue's neurological function. In this case, when patients are operated in eloquent areas of the brain, and we often operate patients when they are awake, in an awake craniotomy setting, Glyline is safe to use while patients are awake to optimize and then to monitor their neurological function. Normal brain tissue will once again not show any fluorescence and will be blue in color. Thus, the same applies to necrotic brain tissue, which has no active, alive tumor cells that would be able to accumulate 5-ALA. Thus, surrounding tissue will not be clearly visible, as we discussed under the microscope. Once again, limitations of use, as we said, the safety in children under the age of 18 has not been established, nor has there been any literature to advocate the use in pregnancy. What I'd like to show is just a simple case study to illustrate the point and how this assists us in removal of the tumor. Our perioperative MRI shows a patient with a medial temporal lobe lesion with strong contrast enhancement, with neurological deficit of his visual fields. And then the associated surgery, one can see where the tumor is then resected by means of the immunofluorescence. Where you are currently seeing the bright area of enhancement, that's where the periphery of the tumor was encountered. Once again, allowing blood to wash out does not alter the fluorescence within the tumor cells itself, and you can, after suctioning away the blood, continue your surgical resection with any adverse outcome to the amount of immunofluorescence that you are actually aiming for. Some other further tips within the surgical cavity: if one reaches normal or alive tumor cells and you get into necrotic tissue, you might get into a position where you do not see any fluorescence within the tumor cavity itself. This does not, however, mean that the tumor has been removed completely, and one has to take into account that within grade 4 astrocytomas, an area of necrosis would be to the center of the tumor, and thus as you breach the medial part of this tumor, you might encounter an area where there is no fluorescence. If you feel that you have not breached into the medial aspect, one has to work through this area of normal fluorescence until you then reach the contralateral side where the tumor will indeed fluoresce again. this will then allow you to also search around the tumor margin for any areas where there might be a small area of fluorescence that might indicate tumor cells or tumor infiltration within the tumor penumbra. This is once again very important, as we know that the amount of tumor resection greatly affects your patient's long-term survival, and we all aim for a 95% tumor resection. Once you've seen now that we've gone from having normal fluorescent light to the normal white light as we are used to in a surgical microscope, one can then visualize the normal brain tissue. And at the 12 o'clock position, one can see areas that have the consistency of a normal brain tissue, and that you would be, as a rule of thumb, reasonably happy with your surgical resection. But this is where Glyline becomes really, really useful. Since you cannot differentiate between the areas of normal tissue and abnormal tumorous tissue, the fluorescence will then indicate where one would have thought the tissue to be normal, that in fact there are still resectable tumor within that space. As you can see, there are still that slight pinkish tumor tissue, which then could be further removed. Just to show you our post-operative MRI, just to give you an indication of how we could clearly go through this area to remove as much as the tumor cavity as we could safely do so. So, in conclusion, the use of the FL400 molecule in conjunction with the Glyline or 5-ALA molecule provides the surgeon with a real-time visual feedback during the resection of the tumor and of the extent of its removal. The use of Glyline is dependent on the adequate training by MEDAC in its use and precautions and contraindications, and Glyline does unfortunately not give us any information about the underlying brain tissue or the neurophysiological function and of the resected tissue. And thus, you need to still pay careful attention to the possible neuropathways that you might encounter, and with the use of your awake craniotomy, neurophysiological monitoring or tractography, this is just one added tool to use in a safe tumor resection for our patients. Thank you very much.
Well, thank you so much, Dr. Jacobus Stein, for this insightful presentation and for sharing fascinating insights into your work. We're going to get to the questions in just a second, but let's now take a look at the technologies that can support HGGB resection. Those are the Avio Digital Augmented Reality Microscope, the M530 OXH Surgical Microscope, and the FL400 Fluorescent Module. And dear audience, if you are interested in learning more about these Leica technologies, then please feel free to request your private session. You can see on the slide that there are numerous options available, so please don't hesitate. We would be very happy to teach you more. And now we are coming to our questions. Thank you to you for submitting your questions, and let's take a look what you would like to know. So, Dr. Stein, the first question is, sir, any use of nanotechnology in this procedure or equipment?
Well, not in this specific procedure. As you know, the molecule is a natural amino acid that just accumulates within normal brain tissue, so there's no nanotechnology involved. With regards to the equipment, that's all up to Leica. You know, they are the leaders in the field of immunofluorescence with the FL400 microscope, so we don't use any nanotechnology. This is an amino acid which can be used with an associated microscope that is with a filter, so actually it can be used in any specific neurosurgical center. It doesn't have to be a very technologically advanced neurosurgical center.
Okay, thank you so much. Next question that we have, Just 1 second. We'll wait until we get it on the screen. What type of tumor would you say is most difficult to remove and why?
Well, tumors that are most difficult to remove are those tumors in eloquent brain areas. One has to take into account that not all tumors are the same, and not all tumors react the same. A low-grade glioma could have a growth pattern very similar to a high-grade glioma, and vice versa. Most difficult tumors are those tumors in medial insular areas on the left-hand side, or any speech-dominant tumor which the patient needs to be awake, and the patient needs to be counseled optimally whenever you perform an awake craniotomy. The use of FL400 and Glyline molecule assists in optimizing your surgical resection, bearing in mind that the patient's safety is almost paramount. And one has to take into account that patients with tumors in eloquent areas need to be approached in a slightly different manner. And we use technologies at our disposal, whether that be awake craniotomies, use of the operating mind with 5-ALA, or even the use of tractography to make sure that we do not we remove as much tumor as we can without causing long-term deficit to our patients.
Okay, thank you so much for answering that question. Then let's see what question is up next. Can a microscope with fluorescence for ICG support other fluorescences?
Well, I think that might be a question for the Leica team, because they will know which are the new technologies and new filters that they might need to use with it.
Hello, good afternoon. It's my pleasure to answer this question. Yes, the answer is yes, absolutely. Microscopes such like the OHX or the Arveo, they can support 3 fluorescences simultaneously. So yes, this is the answer. So you can have up to 3 fluorescences in just one microscope.
Thank you very much, Nuja Neves. So then we'll take a look at the next question coming up. Just a moment, then we'll get it on the screen. Can my department share the Leica microscope used for neurosurgery with other disciplines, such as ENT or plastics?
Well, in our department, we do. Our microscope gets used by various disciplines. It's not only the neurosurgeons but use it, but also the spinal surgeons, our plastic surgical colleagues, and our ENT colleagues use it. Even our maxillofacial surgeons, when they do facial reconstruction surgery with their plastic surgical colleagues, also use our microscope. So you can definitely use it in multiple applications.
Okay, fantastic. So the answer is absolutely yes. Then let's take a look at the next question. Do we have another question? Yes. What does the future of tumor surgery look like according to you, Dr. Stein, in terms of approaches, technologies, and biomarkers?
Well, my personal opinion is that technology is going to play an intricate part of the future of tumor surgery, not only with the use of immunofluorescence, the for FL400 molecule or the Glyline or ICG. We're also looking at the use of intraoperative MRI, and a technology that I personally like quite a bit is the use of intraoperative ultrasound. Use of intraoperative ultrasound as a combination gives you a real-time accurate feedback on your resection, and this works wonderfully with all the other technologies that I've just spoken about. I've used it on numerous occasions with the FL400 filters of the microscope, and it integrates seamlessly with your navigational systems and with patients as well. Patients feel very comfortable using the ultrasound, and there's no real patient problem, as well as from a technical point of view. Although there's a small learning curve, it's something that every neurosurgeon will be easily able to adapt within his practice. With regards to biomarkers, I know that there are obviously a numerous amount of biomarkers that are being discussed and developed at the moment for the use of tumor surgery, specifically with regards to malignant gliomas, as well as immunotherapy in the treatment thereof. But that's not all of it's available in our country, and most of that's only available in Europe under selective conditions. as in the US in selective centers. In Africa, we do not have, unfortunately, any access to those biomarkers at present.
Okay, thank you so much. Well, that was our, oh no, I thought it was the final question, but we have one more. What is the difference in outcomes and success of the surgery with Glyline otherwise?
Well, the literature out there says that Glyline is almost as successful as using an intraoperative MRI. As you are aware, not all centers have got the financial ability to have a large MRI suite available to use as a surgical resection tool for their patients. And Glyline gives you that ability to know that your surgical resectional margins are clean and clear of infiltrative tumor tissue due to a visual representation. The literature out of MEDAC and from Dr. Walter Stummer's unit shows that the use of the Glyline and MRI gives very comparable results.
Okay, thank you very much. So let's see what question is up next. Would it be interesting to have a fluorescence available for low-grade glioblastomas?
Well, low-grade glioblastomas is actually a misnomer. So it's either a low-grade glioma or a glioblastoma. If you're talking about a glioblastoma, you should technically have sufficient tumor tissue that takes up the gliolin or the 5-ALA. So any grade 3 or grade 4 astrocytoma with a high tumor density and a high uptake of the molecule should give you fluorescence. In case of grade 1s, or actually, as a matter of fact, grade 2, low-grade astrocytomas, the amount of gliolin accumulation does not really give you a significant fluorescence, and this would not be an advocated use thereof. If one wants to have a look at low-grade gliomas and a visual representation of your tumor resection, I would personally use an ultrasound with a microscope in deep-seated lesions to assist in real-time resectional cavities, bearing in mind that the patient's neurophysiological status is also and always going to be paramount in your resection. There's no use in removing the tumor if you compromise the patient's neurological condition.
Thank you so much. Tap water versus distilled water versus 9SL, please tell sir.
Okay. Well, I think the 9SL, we're talking normal saline, distilled water, and normal tap water. Normal tap water is absolutely fine and adequate. Why complicate things? You know, every normal water has got normal tap water with it, and normal tap water will be completely adequate. There's no need in trying to get normal saline or distilled water or anything else. Every little variable that you might change would be an influence on your amount of absorption and your amount of targeting 5-ALA within tumor tissue. We know that from normal tap water, the absorption is more than adequate with good results, so I'd stick with normal tap water and discard all other alternatives.
Well, thank you so much. As far as I can tell, that was our final question. But of course, dear audience, as we said before, please do not hesitate. If you have any more questions, if you have any requests, if you want to try out the technologies and have your personal experience, then please just reach out to the Leica team and they will be happy to help. Dr. Stein, thank you again so much for your time, for taking the time. As we know, you have a very busy schedule. We appreciate it that you took the time to be here today to answer our questions, for your fantastic presentation. Dear audience, our Leica 2021 Online Neurosurgical Visualization Summit will be continuing until Saturday. As you can see on our schedule, there are numerous further possibilities for you to gain some great insights and more learning. So please feel free to register. I would like to thank all of you for your time today, for your participation, for your input, for your questions. Have a fantastic day and see you soon.
Bye.
Further possibilities for you to gain some great insights and more learning. So please feel free to register. I would like to thank all of you.